for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto. Today I am joined by Professor David Isenberg from the Lupus Academy Steering Committee. We will discuss the tremendous difficult approach to neuropsychiatric events in patients with SLE and a little bit on the psychological aspects of it. David, welcome and thank you so much for joining us today. So, neuropsychiatric events in lupus, they had a huge burden to the disease. Having had a neuropsychiatric event increases the mortality risk, both compared to SLE patients without neuropsychiatric events and compared to the general population. SLE patients that had a neuropsychiatric event has an increased risk of mortality 11 times on the first 10 years of disease compared to the general population. And it also reduces severely the health-related quality of life and fatigue and persistent impairment throughout life. One of the most confusing concepts in the literature is the reference to neuropsychiatric SLE, both to events and inflammatory and thrombotic and comorbid situations, and not distinguishing them from neuropsychological or neuropsychiatric damage accrual. So, with this small introduction, David, globally, why do you think it's so difficult to manage neuropsychiatric lupus?
So I think lupus, of course, is the great disease for looking like other conditions. But I think nowhere is the challenge greater, where almost anything from migraine to madness could conceivably be a feature of lupus. And I think that's part of the challenge. Patients may present with a whole variety of neuropsychiatric symptoms, some of which you could arguably say are very clearly linked to the pathology, and we'll talk about that in a second, I'm sure, because the neuropsychiatric pathologies are many and varied, and they vary, as you already, from what would appear to be out-and-out inflammation, perhaps linked to vasculitis in some cases, to very clear clotting issues. Patients with high levels of phospholipid antibodies come to mind immediately. But there's a whole variety of other things too. And I think trying to link or to correlate the likely immunopathology with the clinical features that the patients have is very tricky. And even at the level of the very humblest thing, let's say a migraine headache. And one of the very first things I ever did a long time ago was to look at the relationship, or try to look at the relationship between migraines and lupus patients. But I conclude, having looked after a lot of patients with lupus over many years, that as far as migraines are concerned, I think it's fair to say that in a patient who says to you, I did not have a migraine headache ever in my life until I got a diagnosis of lupus, it's reasonable to say that the migraine headaches are likely to be part of their lupus spectrum, if you like. But a patient who says to you, look, I'm now 37, I've just been diagnosed with lupus, but I've had migraines for 25 years, I think it's very unlikely that the migraines are part of their lupus. So that's a nice example of how, one relatively simple thing could have very different causation in a patient with lupus.
Thank you. So, to be a little bit more specific, let's start on the definition and classification of the neuropsychiatric syndromes with the task force from 1999 ACR classification. You were one of the authors in this collaborative task.
Well, it goes back even longer, actually, Raquel, because the first attempt to classify lupus was that of the now called American College of Rheumatology, then the American Rheumatism Association in '71. Then came a bigger revision in '82 and a further revision in '97. In each of those classification criteria sets, there were effectively only two manifestations recognized for CNS lupus: psychosis and seizures. Then in 1999, Matt Liang was asked by the American College to put together a working party, of which, for admission, I was a part. Although the society has said that there were just two manifestations, psychosis and seizures, we, the working party, believe that there are actually 19 different things, 12 central and 7 peripheral. And so the college the American College faces this odd situation that on the one hand it says in its classification criteria set up till 1997 there are only 2 CNS features, but on the other hand the ACR working party says no, there are 19 features. So you kind of pay your money, you take your choice. And even the more recent combined situation with the ACR and you are getting together, they've only increased the neuropsychiatric things to 3 with delirium. So that still leaves this sort of very odd gap between what the working party 25 years ago said and what the combined ACR and ULAR says. So it's a rather uneasy situation, it seems to me.
The working party are from 1999. When this is a huge work and very amazing one to define when to not exactly when, but what to do when specific syndrome would appear in patients with lupus, and what is to study and how to validate that it was a syndrome that could be a part of lupus. And this was really an amazing work. What do you think that currently are the main pros and cons of this classification?
Well, I should say that working party was, as you say, it was amazing, actually. It was, and Matt did a fantastic job in getting together people from very diverse backgrounds. So he got neurologists, he got psychologists, he got rheumatologists with a particular interest in neuropsychiatric problems. And we met in a very intensive way over a 2 to 3 day period. And we tried to recognize, I suppose, from the eminence point of view, what clinical features of central nervous system lupus do you feel you have seen in your career, which you have linked to lupus in a way which is not recognized by the classification criteria, such as aseptic necrosis, such as transverse myelitis, just to give you 2 simple examples. And where we had evidence to support that, we felt we would make use of that evidence. But as we will also, I'm sure, discuss, it remains very tricky with certain items, anxiety and depression perhaps being the classics. So anxiety and depression, most people accept are part of the problem in patients with lupus, but are they truly features of lupus per se, or are they secondary in the sense that, if you were 20 years old and you come and see somebody like you or somebody like me, and we say to them, look, I'm really sorry, you've got lupus and you've got kidney involvement, and you've got this and you've got that, and I'm going to want to treat you with steroids and immunosuppressive drugs and rituximab and this and that, who wouldn't feel anxious and depressed? In fact, you could say that it would be crazy if you didn't feel anxious and depressed. So is that really, truly, or are those things truly features of the disease? Now, I did some more work looking in great detail over we looked at 70 patients and who we gave very, very detailed neuropsychiatric tests to look at the degree to which they were anxious and depressed. And then we repeated those tests. Those tests took 2 to 3 hours to complete, by the way. We repeated those tests 1 year later and 2 years later. And here's what was very interesting about that. The total numbers of anxious and depressed patients, the total number within those 70 patients didn't change that much, but the percentage of those patients who were making up those percentages did change. So some patients were anxious and depressed year 1, not so bad year 2, might have got worse again year 3. So it adds to the complexity of trying to be really sure in any individual patient whether the anxiety and the depression are genuinely part of their lupus psychopathology or just secondary to the nature of having a nasty disease.
We're coming back again for that, but a little bit on the end. As I was just giving an inch before, there's strange literature, the definitions of neuropsychiatric event as an active disease, inflammatory, thrombotic, or even as a comorbid, interfering with, for instance, when the kidney is not okay, what can change on neuropsychiatric events, and then those from the neuropsychiatric damage accrual, not only those that are on STI, the score for damage, but also other damage. What would you say to our listeners to help distinguishing them? What is an event? What is a comorbidity? What is damage on the neuropsychiatric aspect?
Okay, so damage is important to distinguish from activity for all sorts of reasons, not least, of course, because damage implies permanent change. So the gestalt, if you like, of the damage index when we first put it together as part of the International Lupus Group was that to have damage, you had to have something which was present for at least 6 months. So it was uncontrolled seizures for 6 months. But on the other hand, you could have a clear-cut event, which at the time of it happening, a stroke, for example, you can't say that that wasn't necessarily a feature of active disease, but assuming that the complications of the stroke, the loss of the use of an arm or leg, persisted for more than 6 months, the implication of that was it was never going to get any better. And by a parallel assessment of real damage, we felt that if your GFR dropped below 50 mils per minute for 6 months, it was very unlikely in an adult that that was ever going to get back to normal. So damage was always an attempt to look at something which was never going to change or very unlikely to change. And just to sort of throw this in, why is damage important? Well, damage is important because activity leads to damage, and damage is leading to death. And that work was that sort of linkage was shown very beautifully by some work that was done by Dr. Rahman, not Anas Rahman from my own department, but rather from Proton Rahman, who worked for Drs. Urovitz and Gladman in Toronto, who years ago did a fantastic study looking at 270 patients who they followed up for 10 years. And they looked to distinguish the patients who at 1 year into their disease had one or more items of damage and those who had no damage. And they showed that a single item of damage, including CNS damage, of course, if you have an item of damage after 1 year, your chances of being dead 9 years later were increased by 3 times. So that's why preventing damage is so very important. And therefore, you have to be very careful before you ascribe something to damage to make sure it's not ongoing activity. And so that is a problem. Activity always implies something which is treatable, something which you can do something about. Damage is you've kind of missed the boat. It's passed on. It's always going to be there.
Thank you for that. And in the literature, we can see with several cohorts that have been published that only 10 to 30% of the neuropsychiatric events that happen in patients with lupus are due to lupus, to the pathophysiology of it. And it varies according to the specific syndrome. Many times diffuse CNS manifestations and several neuropsychiatric symptoms can be presented at the same time, not all of them completely attributed to lupus. For instance, if you have vasculitis in your brain, and it can lead to organic brain syndrome or delirium, and it can also gives you seizures, especially if you have other metabolic stuff going on. So we need some tools to be more easy to classify them as attributable to lupus and not. And there are actually several tools, Model 1A and B from John Henley, the Alexandra Bortoluzzi Italian algorithm for that, for the attribution, and even the Greek one and the Netherlands one. So what do you think is the current role of the existing attribution models, and how do you think we can optimize them to be used on general clinical settings?
So as you've already implied, attribution is tricky, is very difficult at times. And that, I think, especially in the CNS, is true because clearly a very similar symptom can be brought about by a variety of different mechanisms. And I think for me, the more important question is to try to determine in any individual patient, what is the likely precise mechanism by which this patient has developed a seizure or a psychosis or a foot drop or this or that, whatever. And then we have to begin to sort of examine, well, what exactly can cause CNS problems? So we know from studies that were done at post-mortem, and this is a very famous study published in 1972, I think, out of Baltimore, that 12% of patients at post-mortem were found to have cerebral vasculitis, which was not necessarily identified during life. Now, the trouble, of course, with brain disease, central nervous system diseases, whereas with the kidney and the skin, you can get a biopsy very easily. Brain biopsies, I don't know how you've done, in 30, 40 years, I've requested 3. what I think is interesting is that in each case, I and my colleagues who were thinking through what we were likely to find in the biopsy got it wrong every single time. So brain biopsies can provide very useful information, but they are not done anywhere near as frequently as we do skin biopsies and kidney biopsies, and that's, I think, quite important. I think clearly there are some antibodies which are cross-reactive, and this work goes back also 50 years to some work that was done by Barry Bresnahan then in London before he went on to Dublin, become professor of rheumatology there. And Barry showed that you could find cross-reacting antibodies which bound to lymphocyte surface antigens, but also bound to something in the brain. So the cross-reacting antibody can be very important. We know also from the work that's been done by many different groups that antibodies to ribosomal P, this was the original work done by Keith Elcon and what's going on here? Very nice colleague from Brazil, who the two of them wrote a paper in New England Journal of Medicine in the mid-80s, claiming that something like 18 out of 20 patients with psychosis had this antibody to ribosomal P. And there therefore a huge flurry of papers, which I reviewed some years ago when the first 14 had been published. And it was the classic challenge in CNS lupus. About 7 of those papers said, yes, they agreed that if you have antibodies to ribosomal P, you're more likely to have neuropsychiatric disease, including depression. And 7 papers which said the exact opposite. Well, actually, they couldn't find a correlation. So it's been very tricky to work that out. In some populations, and I don't know why they should be, but in Korea, about 30% of lupus patients were said to have antibodies to ribosomal P. Most of the reports that I've seen put that figure up between 10 to 15%, so a rather lower figure. Then you've got the question of the antiphospholipid antibodies, which clearly are associated with blood clots, and those clots can affect the brain very clearly, and that can be very serious. You could also get patients who even present, I've seen patients present, for example, with a sagittal sinus thrombosis. That was their presenting lupus feature, not a common one, but it does occur. Then there are other mechanisms too, including antibodies to the NMDA receptor, which were first described by Betty Diamond and her husband back in 2001. Those assays are not as readily available in the UK as are the antibodies to ribosomal P, but you can get them. And again, that's been somewhat controversial. Some data supporting their findings, some data not. But for an antibody to be causative of a problem, you've got to have some penetration of the blood-brain barrier, breaking down the blood-brain barrier. And again, that's difficult to demonstrate in reality. It's hard to show. So you've got this whole plethora of possible mechanisms, and I'm sure there are others too, which could be causative in an individual. There may be more than one that's also causative. And you've got other simple things like hypertension, for example. In the patient with renal disease, with poorly hypertension, the chances of having an intracerebral bleed, giving rise to a stroke, is also very high, and I've certainly seen that in patients. So you've got this whole plethora of specific and less specific problems, which makes the whole question of attribution rather difficult in my experience.
And you already entered a little bit on the biomarkers that we can use to help us diagnosing or prognosing neuropsychiatric lupus. What, besides the antibodies that you would want to know just to try to figure out what's going on here, is there another specific biomarkers, both in blood and CSF, that you would think that could be the most promising to higher the probability of diagnosing NP events?
The literature on this is absolutely vast, and I know for a fact that you know more about this than I do, so I'm very happy to follow your advice on this. But I know, for example, that a whole host of cytokines have been looked at, antibodies to neurofilaments have been looked at, antibodies to all sorts of proteins. There was a 52 kD protein which thought to be very important that was reported some 25, 30 years ago, which some people believe might be important too. So there's a whole host of possibilities, but I'm not really, you may have a different view, I'm not really aware that anybody's saying with any absolute certainty the next big biomarker for CNS lupus has to be X or has to be Y. But I'll put the question back to you. Do you
absolutely,
have...
absolutely, absolutely.
I find it very frustrating to read this literature.
We were discussing at our clinic and with the immunological laboratory if we should measure IL-6 to measure inflammatory activity in NPSLE, and then where would we measure? On the blood, on the CSF? Or do we have hard data to support it? So it's there so much on the pipeline, but we do not have, at least yet. Probably in the tertiary and research centers that could be done, but not yet for clinical use.
It's certainly not widely available there, let's put it like that.
Yes, and because we want to be more sure to diagnose it, we don't know. MRI is the gold standard image technique, and God knows the difficulty that we have sometimes in a busy MRI schedule to enter a patient that we think needs to go to the MRI to have the most correct image when we are dealing with NPSLE patients. And there's some rule in some patients to use also SPECT and PET brain image in the clinical practice. How much do you use it? And which were the patients that you would want to have for the SPECT or PET brain image?
So certainly in the course of my career, apart from the advances in treatment, the biggest advances that I've seen have been the advances in imaging of all parts of the body, but obviously particularly the brain. And this is absolutely vital given the fact that doing brain biopsies, as we've discussed, is so hard to do in reality. So MRI scanning gets more and more sophisticated. You can tell more and more. We are doing, as you may know, a trial called the RISAPS trial currently. We're looking at patients principally with antiphospholipid antibody syndrome, but they may or may not have lupus, in which we are able to measure the numbers of white matter high intensity lesions. We can measure not only the number of them, but also the volume of them. So what we've done is to take patients who have had a cerebral event, an arterial cerebral event, and they're treated either with high intensity warfarin, target INR 3 to 4, or rivaroxaban, not at 20 milligrams per day, which is the standard, but at 30 milligrams per day, which has never been done before. And I can tell you we've now finished this trial. We had incorporated, I think, 43 patients, something like that. And they had an MRI scan done, which had this capacity to measure the numbers of these lesions and the volume of these lesions at time 0 and after 2 years. And that's now been finished. We've done all the second scans. And we're now in the process of reading those scans, and those data the results of those data will be available later this year. We're hoping it might end up as a late breaker at ACR or one of the big APS. There's a big APS conference in September. That might be a little bit too early for that, but results of that scan should be out quite soon. But it's been remarkable to me just how incredibly sophisticated these scans are, what they can do, what they can tell. So that's kind of come in more widely, I think, as the level of sophistication with MRI scanning and SPECT scanning, as you say, becomes more sophisticated. So those data will be available later this year. That may give us some very interesting information about not just the APS patients, but also lupus patients in general.
Yes, it's amazing. I do think that we will have more problems interpreting that than actually having the technique available, both the volumetric and the functional one. Actually, a curiosity, the 7 tera MRI technology can almost see the neurons itself. They see the layers, how they are connecting with each other. So it's crazy, and we'll need to learn how to interpret that. Moving to treatment, because that's what we need to do when we see a patient. We need to treat the patient. And all this talk that we are having about is to try to figure out what's the mechanism so we can treat it with the most accuracy as possible. And there is actually no data that has scientific support for the different options of treating NPSLE as per the mechanism beneath it. And if you consider inflammation, you have one approach for inflammation, as in everyone, like steroids. And if you have thrombosis, you'd use anti-aggregation agents or anticoagulations. What do you think about this? And
Okay,
how?
so if we deal with the two major features which everybody recognizes is CNS lupus psychosis, seizures in one sense is somewhat easier in that you're going to use anti-seizure medication of one sort or other. We use a lot of the drug levetiracetam in the UK, seems to be a favorite with the neurologists here. But of course, it also depends on, well, as I said, what the precise cause was. And if the cause of the seizures relates to either a clot or a bleed in the brain, clearly that primary problem has got to be dealt with. So if the problem ultimately, if you sense, relates to untreated renal disease, clearly you've got to treat that first, treat the hypertension if that's part of the problem. So that's part of the problem. With psychosis, my own view is that we wrote up a whole series of about 17 patients presented with psychosis, the first 750 patients that we'd seen. It's very striking, actually, that with those psychotic patients, the patients tend to develop psychosis very early in the course of their disease. That was important. That was interesting. Secondly, that very often the problem doesn't come back again, so that the long-term outcome for those patients is actually quite good, even though at the time it can be very dramatic. And I'll give you an example of that. So some years ago, we had a patient who was a smart lady. She was a PhD biochemist. She had 4 kids, she had a husband, and she said she had voices. And she said to us very calmly, the voice tells me to kill my kids and to kill my husband. But there seems to be another voice which says, maybe that's not such a good idea. And I think that's the difference between the psychotic who has lupus and the schizophrenic, for whom there is no such restraining voice. And schizophrenics have certainly been known to kill patients. To the best of my knowledge, no CNS lupus patient has ever killed anybody, as far as I'm aware. You could prove me wrong, but that's my understanding.
Let's hope it's absolutely true. Yes.
So far.
Let's hope.
The treatment for psychosis and lupus seems to be to rest upon 3 pillars. 1, to use an antipsychotic, that's, I think, quite important. Number 2, to use an immunosuppressive drug, because I think in those patients that does seem to be helpful. And the third thing is time. These patients don't get better like that. It takes weeks or more likely months for these patients to get better. But for many of those patients, after 6 to 12 months, they are substantially better. I've got 2 ongoing such patients at the moment, and that rule has been very important to me to remember. After 1 month or 2 months when they weren't better, I've just said to myself, stay with this, keep patient, it will get better. And after 6 months, those patients have got substantially better. Now one is up to a year and is really pretty much back to normal. And for many of those patients that we've reported anyway, it was a one-off phenomenon, one-hit phenomenon. They had it, it lasted a long time, but they got better, and it doesn't seem to come back. That's not to say that it can't come back, or that there aren't patients who, and I have an example of this, a guy who continues to get his voices years and years after they started, but somehow he's kind of come to terms with it. And he says, yes, I still hear them, but they don't worry me as much. I just kind of ignore them. So that's kind of reassuring. So I think those are the 2 major elements that you have to bear in mind. And the rest, I would say, obviously, I'm painting with a very broad brush here. If you've got migraines linked to lupus, there are all sorts of migraine relieving agents which you can use. Aseptic necrosis, you've got to treat the same that you would treat it whether or not it was a lupus patient or not. And for most patients with lupus, the treatments are going to be the treatment of the particular problem as it would sort of present in any other situation, whether or not they happen to have lupus. What of course is interesting is to try to tie up what is the precise cause of the problem in an individual patient. That may require treatment. So a patient who has a stroke and it turns out they've got very high levels of phospholipid antibodies, you're invariably going to want to treat them with warfarin. So that's going to be your main choice.
And you were using this idea of what to treat for several different neuropsychiatric syndromes. One of the things that strike me currently with the treatment of neuropsychiatric lupus is that if you have a severe manifestation that is supposedly inflammatory, like vasculitis, you would use huge amounts of steroids. And we are on here that we don't want steroids as much as that. And it's clearly for me an unmet need to treat inflammatory neuropsychiatric event that is severe enough that we cannot be waiting for anything else. So how would you see this, and what kind of other drugs you would choose to lower the inflammation on the CNS?
Okay, so we're getting to confession time in this podcast now, Raquel. I'm now going to confess something to you, which I would confess only to you, obviously.
Of course, no one is listening.
Nobody else is listening, exactly. So many years ago, I was asked to write an article called "Intravenous Cyclophosphamide: Goodbye to All That," and it's the article which I most regret ever writing, because in certain circumstances, intravenous cyclophosphamide can be a very effective way to go. And I think for a lot of CNS problems, especially where there is any degree of, or likely to be a degree of inflammation, including vasculitis, I think cyclophosphamide, but given in the right doses, and that's perhaps what we should have a word about, is actually a very good drug. I think the problem with cyclophosphamide was that the old regime, which was of course developed for renal disease by the NIH, simply gave you rather too much. So those patients got a gram of intravenous cyclophosphamide every month for 6 months, and then every 3 months for 2 years. So they ended up getting 14 to 15 grams of intravenous cyclophosphamide. And the work that was done by Fred Husio and colleagues in the European renal arena, as it were, showed that actually, as you know very well, 500 milligrams times 6, 2 weeks apart, is actually just just 3 grams of cyclophosphamide, and it's just as good as the old Russian regime. So you don't have to use as much, but it does, in my experience, help you to minimize your steroids. And of course, you do have the little problem, although I think it's greatly overblown, but the idea of steroid psychosis can be a confounding factor. Although there was a study in Mensa Baltimore years ago where they looked at over 100 patients with so-called steroid psychosis, and they concluded that actually the numbers of patients who had a genuine steroid psychosis was actually very, very small, and that but with those patients, the level of steroids at about 10 was pretty critical. If you gave them more than that, they did become psychotic. If you kept it low, then it was okay. But by and large, for the reasons that we've discussed in the past, steroids are closely associated with damage in its many guises: osteoporosis, increased infection, diabetes, hypertension, etc., etc. So clearly, we want to minimize the doses of steroids. And I think this is probably going to get us to the other very aggravating part of this whole conundrum of treating lupus, which is the absence of data, the awful absence of data in the newer biologic drugs, not so new drugs, when it comes to CNS lupus, because virtually every single new trial of biologic therapy says CNS lupus is excluded. And it drives me nuts because really we desperately need, with some of our patients, to know whether or not drugs like Benlysta, for example, adalimumab, sorry, not adalimumab, Benlysta,
belimumab, rituximab, and anifrolumab, yes.
All of these drugs which are coming into and are widely used now, but the evidence of their effectiveness in CNS lupus is hampered by the fact that every drug trial of a biologic drug says no CNS lupus, too complicated, keep it out. And it's really frustrating. So all you can do in the literature is to go to the odd case here, small case series there. You don't really get the really good information which you can get out of a good clinical trial. It doesn't exist for CNS lupus, and it's a crying shame.
Yes, and there's an additional conundrum that we feel on the clinical practice, that sometimes you do think that the patient is a good patient for belimumab, and then there's always someone that raises the question, but it had a black box for depression and suicide. So do you want to mess up with the brain when the brain is already messed up? And actually, it's really strange, because you do feel that the patient would benefit from that. So that you are an expert in helping design clinical trials. So we're going to take a little bit of that and ask you, how would you design a trial specific to neuropsychiatric SLE?
Okay. So I would certainly accept the fact that it's a difficult thing to do, and I don't think you could cover all of the potential 19 CNS peripheral nervous system features. And actually, from the SLIC group study, so the SLIC group, when it put together its very large patient cohort, which consists of approximately 1,500 newly diagnosed patients, which have been followed up for about years. So we've actually studied very hard, mainly through the good office of John Handley. We've looked at CNS manifestations, and we've asked the question, which are the major CNS manifestations in this group of newly diagnosed patients? and not too surprisingly, headaches, anxiety, and depression rank pretty high. But you do see seizures, you do see psychosis. So it would be, I think, potentially possible to look at patients presenting with psychosis and seizures and just focus on those two major groups. I think to study anxiety and depression in this situation would be a lot trickier. I'm not saying it's impossible, but it would be trickier. But I think if you focus on seizures and psychosis, clearly with psychosis, the numbers of patients you're going to get will be relatively small.
Yes.
We published our figures about 2% of our group who've got genuine psychosis, and I don't think anybody's ever published papers saying it's ever going to be more than 2 or 3%. So you could do a very small study trying to, let's say, if you collected 20 groups around the world interested in this problem, you might, in the course of 2 or 3 years, it will probably have to be an investigator-led study, I suspect. You could probably try to identify, perhaps in the region of 30 to 50 patients, if you've got 20 centers together or 25 centers together, and you had a bit of time to do it, and you could try to distinguish the patients, those that you treated with rituximab, let's say as an example, versus those given more conventional steroids and immunosuppressive drugs, and you could look and see if there was a difference in outcome. There are psychiatric measures, I am informed, which you could use in this sort of circumstances. Similarly with seizures, if you've got a group of patients, it's easy to do because there are more patients who get seizures. The challenge would be to try to distinguish the patients where you could very easily identify the underlying cause, whether it might be related to antiphospholipid antibodies, for example. But again, I think it would be possible to do that and to use a seizure regime on its own, or perhaps a seizure regime accompanied by seizures plus immunosuppressive medications. So you could try to do something like that. But it would certainly need some thinking through. But it would be great if at least one of the newer trials, newer drugs as they come through, and they are coming through now, did allow perhaps even a small number of patients with a history of seizures and psychosis to enter the study. I'm not going to say that will give us a definitive answer, but dare I say it, using the BioLake system, you could capture quite accurately what the CNS manifestations were. And let's say we persuaded the people who are doing studies of Wondermab. Let's say Wondermab becomes available to us. I would say to the manufacturers of Wondermab, listen, would you please allow, say, 5 to 10% of the patients into this trial? I know they mainly got skin and joint disease, but allow 5 to 10% in who've got seizures or psychosis, put them into the trial, and let's see if we can get some handle, some clue as to whether or not Wondermab is going to be helpful to these patients. It wouldn't be ideal, it wouldn't be perfect, but at least it will give us a better understanding and some data, which would be very nice, whether this approach might be helpful.
Thank you for that, David. I said we're coming back again to anxiety and depression, and now I do have a challenge question for you. So these are two of the most common symptoms in the general population, and probably they are more common in lupus. There's some data that shows that. And outside the attribution models, they are outside the classification, and you know that it's challenging research currently on the depression field, in that people that are studying depression are subdividing the depressive patients in those that have inflammatory profile and those that do not have inflammatory profile, and they do not have any other inflammatory disease. And it looks like the similarities of the inflammatory markers and even the functional MRI areas are the same, almost the same, between patients that do have SLE or they have depression, inflammatory depression, they do not have SLE. And how do you see this on the comparison between anxiety and depression fluctuations, as you said before on the trial you did? Some patients fluctuate anxiety and depression, others do have always. So how do you interpret these? How do you see these kind of studies between inflammatory depression and SLE patients?
Okay, so I think that the human brain is capable of responding in probably a limited number of ways to a number of different stimuli. And I think in a way the analogy is with climbing a mountain. You can climb a mountain through the Northwest Passage, the West Passage, the South Passage, or whatever. You can get depression, or what we call depression, or the symptoms of depression, through, I suspect, more than one mechanism.
Yeah.
So I think it's possible to get, for a patient to be expressing depressive ideation, depressive concerns, suicidal thoughts, etc., either through the mechanism of out-and-out inflammation, or perhaps through some less well understood mechanism within the brain itself, which hasn't been so easily recognized. I suspect that the expression of the depressive symptoms themselves can be a reflection of rather different mechanisms which have brought it about, is kind of what I'm saying.
Thank you. Do you want to add anything else to the topic?
Only to reiterate what I said at the beginning, that I think CNS lupus is the most challenging aspect of the disease. As I said, you can argue that anything from migraine to madness may be a feature of lupus. We don't have the readily available biopsy material, which could give us a much better clue as to what the precise causes were of the problems, of the psychiatric problems, of the neuropsychiatric problems in any individual case. And therefore, we have to work with tools. We desperately need more biomarkers, as we've discussed. That seems very important. We need to also to move up the grading system through the MRI scans. We need better quality scans to give us a better idea of what's really going on in the brains of these patients. Perhaps a simpler way to try to identify breaks in the blood-brain barrier would be a useful step forward as well. So I see it as a potential growth area, and anybody who's interested in lupus, I'd encourage them to work on CNS lupus, because it's fascinating. B, if there is a bigger capacity to make breakthroughs, because so little is still understood about this area.
Thank you so much, David. Thank you for joining me today to discuss this huge concern on patients with SLE. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus and development. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next month to more discussion key issues in the management of lupus.